After discussing quite a few videos on hypoglycemia, now it's time to move on to insulin therapy. Insulin, we know, it's one of the essential medicines in the list given by World Health Organization. And it's been rightly given the tag, the wonder drug, because it's the one that changed the face of our allopathic medicine, and it's the one that completely transformed the lives of diabetes mellitus patients, especially in the setting of type 1 diabetes mellitus, where insulin is required for their survival, definitely for sure. And the details of which we have discussed in detail in the previous chapters already. And we also have to know the fact that insulin is one of the most commonly used drugs in clinical practice. And despite the fact that it is commonly used, there are a lot of confusions that are still existing in the form of probably what type of insulin I have to choose for a particular type of patient, or probably in the form of the correct dosing schedule, in the correct dosing regimen. So there are a lot of discrepancies in these things. So this video will try to address and cover up a lot of areas in that perspective. And at the same time, I would like to tell the fact that there is no universally fixed or a standard regimen as far as the insulin therapy is concerned, because there is a great inter-person variability from patient to patient. And in fact, during the same day and depending on how much carbohydrate they are going to take, a lot of factors are going to affect the dosing schedule and the dosing regimen. So we don't really have a standardized or a universal fixed schedule, but we can do a trial and error method, but very scientifically and in an educative way. So that's what this video is all about. So before going into all those things, let us start with the very basics. How does the pancreas function really, and how close are we to achieve something called an artificial pancreas? So that's what we're going to start with first. So what does the pancreas does in reality? So pancreas produces a basal level of insulin. So this is a basal secretion to start with. And this is the one that's going to control the blood sugar levels throughout the 24/7, throughout the day. And of course, on top of that, you're going to take meals, like you're going to take a breakfast, you're going to take a lunch, or probably you're going to take a dinner. And to keep it simple, I'm not adding the snacks here, because even snacks are also very, very important. How much carbohydrates you're going to take, that's also going to determine how much insulin is going to come out from the pancreas. So, of course, with every meal you take, there will be a surge in the insulin secretion. So because you know insulin secretion from the pancreas is glucose dependent, and the more the glucose you take, more the carbohydrate you take, more is going to be the insulin secretion from the pancreas to neutralize those blood glucose levels. And of course, you have two phases of insulin secretion within each prandial secretion like this. So this kind of secretion of insulin in response to the glucose or a carbohydrate load is what we refer to as something called a prandial insulin secretion. Even though in therapeutic terms we can call it as a bolus insulin, but for all physiological purposes and practical purposes we can call it as a prandial insulin. But it has two phases of secretion, which I have discussed in the very first chapter of diabetology. Like it has the first phase where there will be immediate release and a faster release, and there will be a second phase where the insulin will be newly synthesized and will be released slowly over a period of time. So anyways, that each prandial phase itself has two different phases, which I have discussed already. And apart from that, is that it? So that's what the pancreas does, isn't it? No. The pancreas does more than that, because if this is the only thing that pancreas does, you would be able to achieve the physiological regimens using a basal bolus regime itself. Just by giving a basal insulin and giving bolus insulin when the patient takes a carbohydrate meal, you will be able to cover up the pancreatic function. So that's not it. So because pancreas does something more. For example, it detects hyperglycemia as well as hypoglycemia continuously throughout the day, 24/7, and releases insulin accordingly. So it's a glucose dependent insulin release, and this glucose sensing function is done by the glucokinase gene. We know that. So it's going to alter the rates of insulin secretion depending on the blood glucose levels. Alright. At the same time, it can detect hypoglycemia, so that if it goes below a threshold, they will lower the insulin secretion so much, and at the same time there will be release of counter-regulatory hormones. For that matters, we are going to produce glucagon as well. Alright. Even this can be achieved to a small extent with the help of modern devices like Medtronic 670G and bionic pancreas. But there is one thing that cannot be achieved even with any of the modern devices, is the fact that pancreas is going to release the insulin into the portal circulation and not into the systemic circulation. So whatever modality we are using right now, whatever advanced device we are using right now, are able to release insulin only into the systemic circulation, not into the portal circulation. But because this release of insulin into the portal circulation is really, really important, because liver is the most important organ with respect to insulin action, because without insulin, liver is going to produce excessive glucose in the fasting state by producing excessive gluconeogenesis, and a lot of glycogenolytic control, glycogenic control. A lot of things are actually under the control of portal insulin, not the systemic insulin. Even though systemic insulin can have a little bit of effect on the liver, but it's nothing like portal insulin. So the devices are currently not up to the mark. So we have a long way to go with respect to this particular point, where the human pancreas naturally releases the insulin into the portal circulation, not into the systemic circulation. And apart from that, how the insulin is really stored in the pancreas and it's getting released. So this is the principle that is used by most of the insulin that is commercially available right now. So listen carefully to this. So what really the pancreas is? The pancreas stores insulin around this kind of zinc molecules, which I am drawing in red here. And there is going to be insulin hexamer formation. So there will be 6 molecules of insulin that will form as an hexamer. And this hexamer is not active. It's an inactive form of insulin. It's not an active form of insulin. Only the monomers are active. But the idea of this hexamer is to store insulin inside the pancreas so that this hexamers will be slowly released into monomers over a period of time. And this particular principle is the one that is going to be very, very helpful in the setting of whether you have to create a rapid acting analog of insulin or a long acting analog of insulin, or just you want to create a regular human insulin. So fine. But before going into the other details of what is the classification of insulin, let us see the timeline with regards to the insulin therapy. So what all happened in the history? To start with, in 1922, we know Banting and Best started extracting insulin from the animals. So that is the birth of clinical use of insulin. That's where the insulin started getting used clinically. And after that, in 1936, saw the birth of the protamine zinc insulin. And in 1946, we had the birth of the NPH, that is neutral protamine Hedgedon, where Hedgedon stands for Hans Hedgedon, who is the discoverer of this particular type of insulin. And in 1953, we saw the birth of the Lenti insulin. Even though Lenti insulin is not commercially available right now because many of the companies that are producing them have withdrawn them from the market. And in 1980s, we saw the birth of human insulin through recombinant DNA technology. And from there on, there is no turning back. We have been producing only human insulins. Before that, we have been using animal insulins like porcine and bovine insulin, which had a little bit of side effects. But after that, we have only human insulins right now. And in 1992, the first long-acting analog, which is one of the breakthroughs in insulin discovery, that is the glargine, especially the U100 form, which we'll be discussing about the details of it in some time. So glargine U100 from Sanofi came in 1992, and in 1996, Novo Nordisk, its competing company, produced another long-acting analog, that is the Detemer, came into existence. And in 2010, the ultra long-acting form of insulin, and it's one of the breakthroughs again in the insulin therapy, came in the form of Degludec from Novo Nordisk again. Is that it? No. In 2011, Sanofi, in a pharmaceutical race, it released another ultra long-acting insulin in the form of glargine U300, which is much longer acting compared to the original glargine U100. And in 2015, once again, Sanofi saw a little bit of commercial success with the first inhaled insulin that had a recent bit of success. Before that, they have been trying for the inhaled insulin, but not with much success. But in 2015, this company saw a reasonable commercial success by releasing an inhaled form of insulin called as Afrezza, which is also a rapid-acting type of insulin only. And is that it? No. Because this is a field where technology is going to keep developing over and over. And in the future, we have some scopes for even monthly or weekly insulins in the form of probably pegylated insulins, which is being getting tried now. And there has been some researches going on to complex with biochaperone and rapid-acting analogs in the form of something called a biochaperone Lispro. And we are trying to attempt combining the recombinant insulin with EDTA And probably we are trying to combine this recombinant insulin, that is a regular insulin, with the hyaluronidase as well. So why they are trying to do that is beyond the scope of the current discussion. But anyways, these are the researches that have been going on in the field. So who knows, in another 2-3 years, there might be a completely different type of insulin available as well. But let us stick on to what we have right now. We have the short-acting form, we have the rapid-acting forms, we have the intermittent-acting forms, and we have the long-acting forms, and we have the very long-acting forms. That's what we're going to discuss right now. So let us see the classification of insulin with regard to the pharmacokinetics first. What we have in our kits right now. So first is the rapid-acting insulins. These kind of rapid-acting insulins are basically analogs of insulin. So what do you mean by analogs of insulin? So they are human insulins only, but there has been some changes in the amino acid sequence. Some amino acid may be substituted with the other amino acid to make it behave in a different way in the pharmacokinetics as well as the pharmacodynamics. So that's what we're trying to do. So this is what we refer to as an analog. So it's not the same exact insulin molecule, but we have made some changes here and there, 1 or 2 amino acids. And we have the classic short-acting form. This is nothing but the same insulin that is produced by the pancreas, ditto same structure, that's the human insulin only. This is what we refer to as something called as a regular insulin. And we have the intermediate acting forms. We have a lot of intermediate acting forms, and the only famous form of intermediate acting insulin is the NPH, that is neutral protamine H-DON. And remember, NPH is not an analog. I'll tell you why. Because in NPH, it's the same regular insulin. You're going to use the regular insulin only, which will be complex with protamine. There is no change in the amino acid sequence of the regular insulin that you're going to use. So it's not actually an analog. Should not be called as an analog. And we have the long-acting and very long-acting forms. So let us put everything under the long-acting forms, which are also nothing but the analogs. We have made some changes and additions and deletions to the original insulin molecule to make it better. So let us see what are the rapid-acting forms first. Rapid-acting forms, we have 3 rapid-acting forms. One is the Lispro, second is the Aspart, and third one is the Glulicin. And the details of which we'll be discussing in some time. And apart from that, regular insulin is the same human recombinant insulin only. So there is no difference in the structure or pharmacokinetics or pharmacodynamics in that. And intermittent acting insulins, we have a lot of types of intermittent acting insulins. Of course, as I told you, NPH is the most commonly used intermittent acting insulin. Then we had the lenti insulin. Then we had the protamine zinc insulin. Currently, we have something called a protamine aspart by Novo Nordisk. I'll be explaining you about that in some time. And at the same time, we have something called a regular insulin U500. So what do you mean by that? So regular insulin U100 will be a short-acting one, but regular insulin U500 will be a mixed short-acting and intermittent acting type. And at the same time, as far as the long-acting insulins are concerned, these are all analogs only. The first one, the breakthrough long-acting insulin is going to be the Glargine U100, and we had the Dedimer. These are the 2 long-acting insulins which typically provide approximately around 24-hour coverage. But currently we have ultra long-acting insulins or very long-acting insulins which provide extended coverage even beyond 24 hours. In the sense, we have the Glargine U300 and we have the Degludec, even though Degludec came before Glargine U300. So what you're really seeing is the fact that by changing the concentration of an insulin, you can actually change the pharmacokinetics and the pharmacodynamics of that particular insulin. For example, U100 regular insulin contains 100 units per ml. So it will be a short-acting one. But if you increase the concentration of the insulin to 500 units per ml, so that's regular insulin U500, it will become a mixed short-acting and intermediate-acting insulin. Similarly, the same Glargine, which is U100, having 100 units per ml, will be behaving like a long-acting one. But if you increase the concentration to 300 units per ml, that is Glargine U300, will be very long-acting, will be acting for more than 24 hours. So changing the concentration of insulin can actually change the pharmacokinetic properties of that insulin. That's the take-home point. So to understand all this, we need to start our understanding with the classic regular insulin, U100, to start with. Because it has some classic pharmacological profile, which you have to know. For example, what will be the onset of action and what will be the peak action, and what will be the total duration of action, how long it will be acting for. So regular insulin U100 is the basic to basic type of insulin. That's the same human insulin that is coming out of the pancreas. So we'll have its onset by approximately 30 minutes, which is slightly delayed, and the peak effect will be reached in approximately 2.5 hours to 5 hours, and total duration of action will be there for 4 to 24 hours, and it depends on a variety of factors which will be discussed subsequently. So why this classic pharmacological profile is there? Why it starts acting a little late, around by 30 minutes, and why it has its classic peak of around 2.5 hours to 5 hours? Not why it is not very immediate, nor why it is very late. So to answer that, we need to understand when you are injecting this insulin in the subcutaneous route, they're going to form hexamers. With zinc in the center, monomers will associate to form hexamers, like how we saw in the pancreas. And remember, these hexamers are very stable, and most of the times they will be large enough to enter the capillary circulation, which means they cannot enter the capillary circulation, and it takes some time for them to get dissociated into monomers from the zinc to enter the capillaries. So it takes some time. So that is the reason why it is slightly delayed in onset by around 30 minutes, and to achieve the peak effect, it takes around 2.5 hours to 5 hours. So this is the basic principle, because to produce a long-acting form of insulin, you have to make these hexamers more stable, or you have to produce some other complex which is more stable than the hexamer, so that insulin will be released slowly for a longer period of time. That's the basis of the intermittent-acting insulin and the long-acting analogs. As far as the rapid-acting analogs are concerned, to produce a very fast-acting insulin, you need to prevent the formation of these hexamers so that they remain in monomers as much as possible, so that you will get a rapid-acting and a very fast-acting type of insulin. So that's what happens in the setting of Lispro, Aspart, or Glulicin. So where they usually do not form hexamers as much as possible, and they remain in monomers, so that they will be very rapid and fast-acting forms. So the onset of these rapid-acting analogs will be within 5 to 30 minutes, very, very fast-acting, and the peak action will be exerted by around 30 minutes to 3 hours, and the total duration of action will be there only for 3 to 5 hours, where most of the rapid-acting analogs will be acting only for 3 hours in practical scenarios. And apart from that, we have Aspart, and the same Novo Nordisk company that produced Aspart has produced another type of Aspart that's called a fast Aspart, otherwise referred to as a Fiasp. This is nothing but a fast Aspart. And why you should have this, we'll be discussing subsequently in the rapid-acting analog section. And apart from that, we have the classic NPH form of insulin, that is the neutral protamine hedged on. We have a variety of other intermittent-acting insulins as well, but let us see the profile of NPH. So onset of action of NPH will be there in 1 to 2 hours. The peak action will be exerted in 4 to 12 hours, and the total duration of action will be there for 14 to 24 hours. Even though most of the studies tell that NPH will have a total duration of action of approximately around 16 or 17 hours, not more than that for sure. And what they did in NPH? NPH is basically not an analog, because you are complexing insulin with protamine. So this is the same protamine that you have been using for the treatment of heparin overdose. So, and we have complexed the regular insulin, nothing but the same U100 regular insulin, and we have complexed that with protamine. And this complex dissociates slowly over a period of time, a little slowly compared to the regular insulin. That's why it is an intermittent-acting form. And we have many other forms of intermittent-acting insulin. For example, we have the classic NPH, where I told you we are just complexing with protamine. And what is the insulin you are going to use? It's the regular insulin that you are going to use. And we had the lenti insulin, where we complex zinc with regular insulin, which means you are giving excessive zinc even before the insulin is injected into the subcutaneous area. So if you are giving excessive zinc, they form hexamers even before you inject into the subcutaneous area, so that they'll be relatively more stable, and the hexamer formation will be more compared to that of the standard regular insulin, so that it will be dissociating over a longer period of time. Currently, lenti insulin is not available in many places because the companies that are producing them have slowly withdrawn their production. And we have the protamine zinc insulin, which follows the same principle, but here we will be complexing with zinc, protamine along with regular insulin. So this works with the same principle as we discussed already. And this is also not available right now in commercial market. Only thing that is most commonly used commercially right now is the NPH, that is otherwise referred to as isofan insulin. And we have two other interesting forms of intermittent-acting insulins, like in the form of probably the protamine aspart insulin, which is produced by Novo Nordisk. They proved that combining aspart, which is actually a rapid-acting analog, with protamine, and this combination becomes an intermittent-acting form. And it works, yes. If you take their companies Novomix or any other intermittent acting forms. So it will be actually an aspart with protamine combination. So they don't really use the regular insulin protamine combination, which is called as a standard and a classic isoform insulin, that is NPH. And fifth is another, like interesting form of intermittent acting insulin, that is a regular insulin only, but it will be called as U500 because you have increased the concentration. You have dumped more molecules in the same amount of volume. So that is 500 units per ml. And now if you have increased the concentration, as I told you before, it's going to have a little bit longer action. Like for example, this regular insulin U500 will become intermittent acting type of insulin, and they will have the same pharmacokinetic profile like that of NPH most of the times. But books will tell you this as a mixed short acting and intermittent acting insulin. So last two are very interesting, isn't it? Very interesting forms of intermittent acting insulin. But nevertheless, let us move on to the long-acting forms of insulin. What are the long-acting forms? We have the classic glargine and detimer. So what they did in glargine and detimer, so in glargine they made some changes in the amino acid sequence which will be discussed subsequently, and more importantly they made the glargine to have a pH of approximately 4. That's the isoelectric pH for glargine, which is a lot acidic in nature. So because it is acidic and at the same time they have made some changes in the insulin molecule, they tend to form something called crystals. So this crystal formation is the one that is responsible for slower dissociation of insulin molecule over a longer period of time, and that is why it is longer acting by approximately 20 to 24 hours. So it provides a 24-hour coverage. So let us talk about detimer later on. I'm not going to discuss detimer right now. But what they really did in glargine U300 is very simple. They took the same glargine molecule and they have just increased the concentration to make it very long acting form. And as far as the degludec is concerned, in the degludec they made some changes. So in the insulin sequence, the amino acid sequence, at the same time they have added something called hexadecanoic acid, which will be discussed subsequently. So which made them to form something called dihexamers even before you are injecting that molecule into the subcutaneous area. So which means to start with in the pen itself, the molecules will be associated to form dihexamers. So upon injection into the subcutaneous area, they form a depot of insulin. In the sense they will be forming aggregates of insulin. These aggregates means they form something called multihexamers. Initially to start with they had dihexamers. After injection into the subcutaneous area they form something called multihexamers, which forms depot of aggregates of insulin, which will be dissociating very, very slowly over a longer period of time. That's why the company claims the duration of action of degludec is approximately around 42 hours. So that's why glargine U300 and degludec is often referred to as something called ultra long acting forms of insulin. Having known about the basics of the pharmacological profile of different forms of insulin, now it's time to move on to the classic regular insulin, and which is the basic to basic insulin to start with. We are talking about the regular insulin U100. Remember, U500 will behave differently as per the pharmacological profile, but U100 is the classic basic insulin, which is the same human insulin, which is short acting in nature. And like the structure is not going to be any different. It's obtained by recombinant DNA technology, the same human insulin only. But I would like to highlight these 3 amino acids in the B chain, because the last 3 amino acids, the 28, 29 and 30th position in the B chain, which consists of proline, lysine and threonine, is very, very important, because these are 3 amino acids that we are going to substitute with some other amino acid in the setting of creating a rapid acting analog. So that's why I'm highlighting that. And at the same time, the B3 asparagine is also very important, because this is also something that can be substituted in the setting of a rapid acting analog like glutazine, which will be discussed subsequently. And the 21st position of the A chain, that is A21, which is made of asparagine, is also something to be noted, because that is where we are going to make a changes in the setting of probably insulin glargine, which will be discussed subsequently. So I want to remember these 5 amino acids, the 28, 29 and 30th position of B chain, that is proline, lysine and threonine respectively, and the 3rd position in the B chain, that is nothing but asparagine, the 21st position in the A chain, that is asparagine once again. So this is where we are going to play around in the setting of rapid acting analogs. Remember, majority of the changes in analogs will be related to the B chain only, and A chain will have very little changes. Now let us see the pharmacological profile of regular insulin. So regular insulin takes some time to start with. So it takes 30 minutes. It has a delayed rise. It forms a peak and slowly it reduces its action and has something called a definite tail effect, which we'll be discussing after some time. So this could be a probable profile, not exact one, a probable profile of how a regular insulin acts. So let us see the profile. So if you give injection, it takes at least 30 minutes to start acting. We know that. And it has a very slow rise. You can see it's not having a very rapid rise. It has a very slow rise. And to reach a peak, it takes around 2.5 hours to 5 hours. And we know that as well. And this slow rise is very significant in clinical settings because there is a risk of post-meal hyperglycemia. And it's a definite risk. And that's where your rapid-acting analogs are going to score. So in regular insulin, with the use of regular insulin, there is a definite risk of post-meal hyperglycemia because of its slow rise. And at the same time, it has something called a tail effect. You can see during the end of its waning phase of its action, there is some tailing effect is there. So this tail effect has both advantages as well as disadvantages. So it has more disadvantage than advantage. Let us see the disadvantage first. It can produce hypoglycemia, which means the patient is at more risk of hypoglycemia because of the prolonged action of regular insulin. That's why we told it's around 4 to 24 hours. We really don't know how long the tail effect will be, and it depends absolutely on the patient type. And one probable advantage with this tail effect is the fact that it provides a small basal coverage. This is very useful in the setting of school-going children, because school-going children, very commonly in type 1 diabetes mellitus patients, we are going to use rapid-acting analogs only. Rapid-acting analogs, as I told you, is going to act only for 3 hours. So it's going to cover the morning breakfast very nicely, no problem at all. If the child is taking breakfast at 8 a.m. in the morning, if you inject them at 8 a.m., they're going to cover that breakfast-related hyperglycemia very nicely. But the effect will wane off by around 10:30, 11 o'clock. But if the child takes a snack by around 11, 11:30, so that snack-related hyperglycemia cannot be covered by the morning rapid-acting forms. So that is the reason why for this particular unique group of children who cannot take insulin in the school, you can substitute the morning rapid-acting with the morning regular insulin, which has a prolonged action that can cover the morning 11 a.m. or 10:30 a.m. snacks as well. So that is why only in that kind of scenarios, you can prefer regular insulin. But apart from that, the rapid-acting analogs as prandial insulins are the standard of care right now. Regular insulin is going out of date. And at the same time, we have another short-acting form of insulin that is called as U500. Actually, you should not call it as a short-acting one because this is a mixed short-acting and intermediate-acting. This is the regular insulin U500. We have just increased the concentration of the regular insulin. The original is U100, as I told you. This will contain 500 units per ml. So increasing the concentration, the pharmacological profile will be much similar to that of NPH. So you should not actually call it as a regular insulin or a short-acting insulin. It is mostly of a intermediate-acting type only. So books will tell you it's a mixed short-acting and intermediate-acting form of insulin. What is the usage of this regular insulin U500? Usually we don't have much use of it, but we can use in certain type 2 diabetes mellitus patients who have extreme insulin resistance, where the total daily requirement of insulin, that's the total daily dosage, exceeds 200 units per day. So in that setting, probably you can prefer this form of U500 as a prandial insulins, which will have a much higher basal coverage, and your other insulin requirements may be a little lower. So that's why we use it. Apart from that, it has very limited use. Then we are moving on to the rapid-acting analogs. We have 3 rapid-acting analogs, we know that. So one is the Lispro, and second is the Aspart, and third is the Glulicin. So what are the changes that are made in this kind of insulin? So as I told you, in the 28th and 29th position, you should have prolin and lysine. So but what they have done in Lispro is the fact that they have flipped over. So the 28th and 29th position, so that the 28th, instead of prolin, they contain lysine, and the 29th, instead of lysine, they contain prolin. That's why it's called as lysine prolin. In 28 and 29, that's called a Lispro. And we have insulin aspart. So what they did in insulin aspart is very simple. In the 28th position, naturally you should have prolin over there. But what they did is they have changed into aspartate. So that's why it's called as insulin aspart. And in glulicin, it's quite simple again. In glulicin, the 29th position and the 3rd position has been changed, substituted by different amino acid. In the 29th position, naturally you should have something called lysine, we know that, but they have changed into glutamate. And in the 3rd position, you should have asparagine, which we have discussed already in the previous slide. So in this case, they have substituted with lysine. So that's why it's called a glulicin. So glutamate and lysine has been substituted to the usual amino acids. the pharmacokinetics of the rapid acting insulin is going to be very unique in the sense that they're going to be very fast acting. They're going to produce a very rapid and a steep rise, and the peak will be achieved much faster and much higher, and they're going to have a faster waning effect without any tail effect at all. So this is an approximate profile of the rapid acting insulins. To start with, let us start with the onset of action, very, very quick, within 5 to 30 minutes. And this is the reason why some of the rapid acting analogs have been marketed as insulins that can be taken even after consuming meal. Remember, for regular insulin, you have to definitely consume before the meal only. There is no point in consuming those insulins after the meal. In fact, you have to take at least 30 minutes before the meal, because they start acting only after 30 minutes. Because they start acting within 5 minutes or 10 minutes, these rapid acting analogs, you can just inject insulin just before the meal. Or sometimes you can start injecting the insulin with the meal itself. So there's no problem because they act so fast. And there are some insulins which have been marketed as insulins which can be taken even after the meal has been consumed, even though that is not really advisable. But in the setting of a children, for example, they take a snack inadvertently without taking the insulin. In that setting, even if after they have taken the snack, you can actually inject the insulin, no harm at all. And with special regards to glulisin, which is produced by Sanofi, and that is the insulin that has been marketed initially as one type of insulin which is so fast acting that you can even start injecting after the meal has been consumed in the setting of inadvertent meal intake, if you have forgot to take the insulin. This is very common in the setting of children where you're going to have an erratic meal intake. You really can't ask the children to wait for 30 minutes before taking a meal. So after injecting the regular insulin. So rapid acting analogs are the standard as far as the prandial insulins are concerned in children as well as anyone with type 1 diabetes mellitus. So to compete in the pharmaceutical race, Aspat also created something called a fast Aspat, that's called a FIASP, otherwise referred to as new Aspat, which also has been claimed to act so fast that you can inject it after taking the meal. So currently there are only 2 insulins which can be taken after the meal as per the company's marketing. One is the glulisin and second is the fast Aspat. Remaining 2 types of insulin, the original old Aspat and the Lispro, should be taken just at least 5 to 10 minutes before the meal, or at least at the time of taking the meal. So that is the idea. So after the meal means only glulisin and fast Aspat as per the company's claim. And you can see that the rise is going to be very, very fast. There is no delay in the rise at all. So very early rise and a faster rise. And you're going to see that the peak is also very, very high, higher peak compared to that of the insulin. And the peak is usually achieved much, much faster within 30 minutes to 3 hours. So that this early rise and a much higher peak will act in unison to prevent the post-meal hyperglycemia, which is very common in the setting of regular insulin, that is avoided in the setting of a rapid acting analog. And what you can note is the fact that there is literally no tail effect with that of the rapid acting analogs. If you do not have the tail effect, you will have reduced risk of hypoglycemia in the fasting state. Suppose if it takes around 4 or 5 hours to consume the meal again, so in between you will not develop hypoglycemia, which is very true in the setting of a NPH or a regular insulin. So let us summarize the unique advantages and the disadvantages as far as the rapid acting analogs are concerned. Advantages, of course, they are very fast acting and quick acting, so that you can inject just 5 to 10 minutes before the meal. So in the setting, for example, you want to go to a restaurant, a type 1 diabetes mellitus patient goes to a restaurant, sees some food and he wants to eat. So regular insulin is a painstaking process. You inject and wait for 30 minutes, see the food and sit over there and then start consuming the food, which is really not good in the setting of children especially. So when you go to a restaurant, you want to eat a snack, you go, order the food, inject the fast acting insulin, within 5-10 minutes your food will come and you can start eating, no problem at all. There's no waiting time. So that's the flexible cushion that your rapid acting analogs are going to use. That's the biggest advantage, flexibility for the patient. And apart from that, second advantage is the fact that it's going to have a early and a higher peak. And this is effectively going to control the post-meal hyperglycemia. The surge after the meal has been taken will be effectively controlled because it rises very quickly and a higher peak, so that the effect will be much higher in the peak stage to control the post-meal hyperglycemia. And number 3, another unique advantage is the fact it's going to have a reduced risk of hypoglycemia if your meal spacing is a little bit higher. For example, take at 8 a.m. in the morning and next meal is at 2 a.m. or 2 p.m. or 1 p.m. in the afternoon. So you have that 5 hours gap. So in that time, you will not have hypoglycemia because it acts only for 3 hours. Only the morning breakfast will be covered. So reduced risk of hypoglycemia in the fasting states. And the disadvantages, of course, is going to be the cost, because it's a costly affair, at least 2 to 4 times more costly compared to that of the regular insulins. And apart from that, the long-term effects on the HbA1c is not very clearly known, even though there are many small and multi-center trials which have proven that HbA1c control is as good as the regular insulin, but still the long-term HbA1c control has not been proven consistently by many of the bigger trials right now. And I mean, trials have not been established right now. It's not like they haven't been proven. It's not been established right now. So we need some more evidence for that. And apart from that, the third disadvantage is the fact that you might be needing a higher basal dose of insulin. That's not a big problem usually, but that's one sort of advantage. Why you need a higher basal dose? Because there is no tail effect and they are not going to cause any kind of prolonged action, and there is not going to be any basal coverage if at all. So which is very true in the setting of regular insulin. In regular insulin, your basal dose will be a little lower because that itself gives a little bit of basal coverage. But as far as the rapid acting analogs are concerned, you need a higher basal dose because they don't provide any sort of basal coverage. After knowing the unique set of advantages and disadvantages of rapid acting analogs, let us move on to the intermediate acting form, that is the neutral protamine H-DON, that is NPH. NPH is nothing but the same regular insulin, so I'm not going to change the structure at all. The same human regular insulin U100 that will be complexed with the protamine. That's all. So which means they are going to form crystals of NPH, that's called isoform insulin, and these crystals will dissociate slowly over a long period of time compared to that of the regular insulin, so that they will be intermediate acting forms. To see the pharmacological profile, it's very distinct. So they're going to produce a delayed peak and they're going to have a waning effect over a period of time. So this is very distinct compared to that of the regular insulin, where the onset of action after injection will be around only 1 to 2 hours, and there is a definite peak and a very distinct peak is produced. And this peak will happen around 4 to 12 hours. So because it's having an extremely slow rise, this cannot be used as a prandial insulin, or you cannot use it to cover the post-meal hyperglycemia, not possible at all. So you can use only it as a basal insulin in resource limited settings. And at the same time, because of the distinctive peak that's going to happen around 4 to 12 hours, so peak action is around 4 to 12 hours. So most of the times when you inject this before the meal, by around 4 to 12 hours mark, when the patient is not taking a food, there is an increased risk of hypoglycemia, because that is the time the peak effect is produced. To avoid this, patient might be needing to take a snack in between, where the patient may be needing to take a midday snack or probably a midnight snack to avoid this midday time or a nocturnal hypoglycemia. So if the patient is taking NPH for basal coverage twice a day, you need to give at least 3 major and 3 minor snacks, which is literally impossible in the setting of type 1 diabetes mellitus and children, where they're going to have an erratic meal pattern. So now the use is largely restricted to type 2 diabetes mellitus patients in the form of premix or split mix combinations. And again, this premix and split mix combinations are going to have erratic control, and they are unphysiological ways of giving insulin therapy, especially in the setting of type 1 diabetes mellitus. So we don't use in them. So it's largely limited in the resource limited settings, where the patient will not be able to afford the higher cost of either long acting analogs or rapid acting prandial insulins. Apart from that, there is a considerable variability in control of glucose with respect to NPH within the same day, even within the same patient, by approximately 20 to 40%. This is probably attributed to the crystal formation in the vial or in the pen. So where the crystals tend to deposit a little down, so that if you tend to withdraw the insulin from the vial and you try to inject, you're only taking superficially, where the high concentrated crystals will be at the bottom, resulting in hyperglycemia. Even if you avoid that by rolling the pen and the insulin vial properly, still it is associated with a significant variability by approximately 20 to 40%, all of which makes the control very, very erratic, and there is a realistic chance of getting both hyper as well as hypoglycemia with NPH. Moving on to the long-acting form, that is the Glargine, which is a breakthrough insulin, came in 1992 by Sanofi in a brand name called Lantus. That's the original drug. Then we have a lot of biosimilars right now in the form of, probably example is Basalog, where in Glargine they made an interesting substitution. So what they really did is they added extra to arginine, and they've created new 31 and 32nd position. They've added extra arginine in there, and they've not touched other amino acids in the B chain. And in the A chain, they have changed the asparagine at 21st position to glycine. So that's the name, glargine. Glycine and arginine, that is substituted in an insulin, is what we refer to as a glargine. And what really this meant to them? So this change made the isoelectric pH to shift to something called a pH of 4, so which is an acidic pH. And in the acidic pH, they tend to crystallize. And these crystals are going to be very, very stable. And they're going to release insulin for a longer period of time. So they're going to have a prolonged action. And one important point to note is the fact that this insulin is basically acidic in nature, and that is the reason why this is one insulin where you should not mix with any other insulin, for sure. Never. So NPH can be mixed with others, your detimer can be mixed with others, and your degludec also can be mixed with others, but none of the glargine forms should be mixed with any other insulin because it's having an acidic pH. Very, very important and notable point. And what we really want in the long-acting insulin. So whenever you talk about a long-acting insulin, I didn't describe much about this. What do you really want? So we want a true basal coverage. That's what. So the prandial coverage is typically given by the rapid-acting analogs best, and to an extent by the regular insulin. And regular insulins can give only a very small basal coverage. But the pancreatic basal insulin secretion, which is the need of the heart to control the fasting hyperglycemia, can be done by a proper basal insulin, which is going to act for 24 hours. So we need a basal insulin that's going to act for 24 hours continuously at a stable level without producing any peak, because that's how pancreas works. Pancreatic basal secretion does not have any peak. Only during the prandial stage they produce a peak. So we want something like that. So have we achieved really? So what is the onset of action of this long-acting insulin? Approximately around 1.5 to 4 hours. Is there a peak? Really, there is no peak. But even though the companies claim that these are peakless insulins, but there is a definite peak with detimer. That's why I remember D for definite and D for detimer, and it's a definite peak. And it's been proven by multiple studies. And there is a very small peak, but it's insignificant. You can take it as a peakless only, but there is a real small peak with that of glargine U100, which we have been discussing some time back. And there are two other insulins like degludec and a glargine U300, which are basically true peakless insulins. This doesn't have any peak at all. So to be honest, these are the two insulins which are the true basal insulins, but very costly. But detimer has a definite peak, so relatively not very suitable for basal coverage. We'll discuss in some time. As far as glargine U100 is concerned, it's very less costly, so it's also suitable for basal coverage in a relatively better way. It's a very good insulin, to be honest. And as far as the duration of action is concerned, it should be for 24 hours. It will be full basal coverage throughout the day. That's what we want. So most of these insulins satisfy this criteria. Even though detimer acts only for 18-20 hours and glargine acts for 20 to 22 hours, where there is a waning effect after that. But these insulins are truly peakless and they're going to give a full 24-hour coverage. These very long-acting insulins, degludec is supposed to act for approximately 42 hours and glargine is supposed to act for approximately 34 to 36 hours, the U300 form. So these forms are very, very good for basal coverage, even though they are highly costly. And if you want a low-cost insulin but a better basal coverage, you can go for glargine U300, which is of low cost as of now. But anyways, fine. So this is what we want and this is what we have. And all these insulins what we are going to discuss are better except the detimer, which we'll be discussing in some time. So what is the mechanism of action or the pharmacology of the glargine U100 form? Remember, we are talking only about the U100 form here. We are not talking about the U300 form. So glargine rises very slowly. It doesn't reach a peak, even though there is a small peak that is demonstrated and the levels will be stable over a long period of time. And slowly it has some waning effect towards the end of the day. This is a classic glargine U100's profile. So where there will be having a slow onset, which takes approximately around 1.5 hours to 4 hours. And there is a small peak. And you not worry about that. And they have no significance. And it's a very insignificant one. Because of that, there is no risk of developing any hyperglycemia significantly in the middle of the day or the middle of the night. and the levels are stable over a long period of time by around 20-22 hours, but still it has a small waning effect by 20 to 22 hours. Even though the company claims to act for around 24 hours, but there is a small waning effect by 20-22 hours, where there is a risk of small rebound hyperglycemia at the end of the day, at the end of 24 hours. So what are the unique advantages of glargine? It provides an approximate 24 hours per day coverage, so it can be given only once a day, where your NPH should be given twice a day for adequate basal coverage, because it's going to act only for 15-16 hours to the max. But since it acts for 24 hours approximately, it can be given once a day formulation. There's no problem in that. And at the same time, since it provides a full day coverage with no peak, to be precise, it can be given in any time of the day and irrespective of the meal status. You don't worry about the meal status at all. Suppose if the patient wants to take injection at 5 p.m. daily, let them take at 5 p.m. If the patient wants to take at 8 a.m. in the morning daily, let them take at 8 a.m. daily. So you can give any time of the day, no problem at all. And you can give it irrespective of the meal status. Doesn't matter whether the patient takes a feed or doesn't take a feed, doesn't matter. You can inject this. This gives a lot of flexibility from the patient's perspective, where your regular insulin, rapid acting analogs, and intermittent acting insulins like NPH should be given before a meal for sure. It cannot be given after the meal or with the meal, except for the rapid acting analogs. But this particular long acting insulins, especially glargine and degludec and glargine U300, can be given any time of the day, irrespective of the meal status. But one small point with regards to glargine that you have to note is the fact, even though I mentioned it's any time of the day, it should be a fixed time, and you should not give it erratic times. For example, if you take it 8 a.m. today, tomorrow morning also you fix at 8 a.m. Day after tomorrow also you fix at 8 a.m. It's not like you should take it 8 a.m. today and 5 p.m. tomorrow evening. So it doesn't matter. You should not do that, because it's only providing a 24-hour coverage. If you're going to take it 8 a.m. and you're going to take it tomorrow 5 p.m. and by tomorrow 8 a.m. your action would have waned, and from 8 a.m. to 5 p.m. you are uncovered with any sort of insulin, and there is a risk of rebound hyperglycemia. So you have to be a little careful over there. And as far as the dosing is concerned, the dose required is very much less compared to that of NPH, where you have to reduce the dose by approximately 20% if you are shifting from NPH to glargine, because it's more efficient compared to that of NPH, and it's unlikely to have a erratic control compared to that of NPH. And there is a lesser chance of hypoglycemia compared to that of NPH, and it's a very good basal insulin at a low cost. As I told you before, it's one insulin that you should not mix with any other type of insulin, because it is acidic in nature. Its pH is only 4. And in fact, many guidelines suggest that you have to give glargine in a separate site compared to other insulins. Even in the same site, you should not inject 2 insulins if you are using glargine as a basal coverage, because of its acidic property, which can alter the properties of other types of insulin. Because it's acidic in nature, injection of glargine can produce a stinging sensation. And this kind of stinging sensation after injecting glargine can be avoided by cooling down glargine to the room temperature, because most of the insulins will be stored in the fridge, not in the freezer, in the fridge at 2 to 8 degrees Celsius. But if you are using just like that in the cold temperature, it might produce a sort of stinging sensation because of the acidic property. So if you cool down to the room temperature, that stinging sensation will be much lower. Even though glargine can be given in any site, it's advocated that it's better to give in the thighs, but remember, these are all only practice points, but not really working out in theory. Especially for exams, you not do like this and all. But it's better to give any side, not a problem, but it's practical that glargine can be given in the thighs in the best way. So after knowing about glargine, it's time for detemer. What change that they have done in detemer is very simple. They have removed the B30th position, that is threonine. So you can remember like that, it's a deletion of threonine at 30th position, T, det. Then what they did is they added this extra myristic acid, which is a fatty acid that provides stability for the molecule to have a prolonged action. So you can remember as extra myristic acid. So deletion of threonine with extra myristic acid is detemer at B30. So if we take the profile of detemer, it's weird. It's going to mimic a little bit of NPH. Even though it's better than NPH, it's not better than glargine, definitely. So if we take the profile, there is a definite peak, and they're going to wane off by approximately 18-20 hours. It's not going to have a full 24-hour coverage. It's not a true 24-hour insulin, to be precise. So the idea is it produces a definite peak, but not a very significant peak or a distinct peak like that of NPH. So there is a reduced risk of hypoglycemia compared to NPH, but there is a definite risk of hypoglycemia, but more than glargine U100. At the same time, the waning effect is faster, like approximately 18-20 hours it starts waning. So there is a definite risk of rebound hyperglycemia in the next day, so which you have to consider it very seriously. It's available in the brand name called Levemir, produced by Novo Nordisk in 1996, but right now, many practitioners are withdrawing the use of Detimir because they do not really find it much useful. And comparing the dose of Detimir, you might be even needing to have a higher dose compared to that of NPH by 10 to 15%, where glargine need to be used in lower dose because of its very good action, but Detimir is not that good light of glargine, so you might be even needing a higher dose when you are shifting from NPH to Detimir. You have to be careful about that. At the same time, Detimir is associated with more erratic control compared to that of glargine U100. That's why it's getting withdrawn slowly. And the next breakthrough insulin, and it's really a breakthrough, is degludec, which came in 2010 under a brand name called Tresiba by Novo Nordisk. Maybe this is an insulin to cover up the failure of Detimir. So they released this degludec, which is really a huge success, because what they did is they removed the B30th threonine as usual, and they have combined a glutamate spacer. And they've added a glutamate spacer to the B29 lysine, and to the glutamate spacer they have added something called a hexadecanoic acid through a lot of research. So you can remember degludec something like this. So DE stands for the deletion of threonine at B30, and GLU stands for glutamate spacer, and DEC stands for hexadecanoic acid, so degludec. So this is otherwise referred to as something called a DESB30 insulin, because the alterations is principally made at the B30 portion only. So what is the pharmacological profile of degludec? Degludec is a truly peakless insulin, where the onset starts very slowly, it reaches a very stable level without achieving any sort of peak, and is going to maintain the stable levels over a very long period of time, even for more than 24 hours. So which means the total action of degludec is supposed to be approximately 42 hours as claimed by the company. But if you ask about the peak, they do not produce any peak, and it's a true peakless insulin. Even though all the long-acting insulins in exam you remember as peakless insulins, but the true peakless insulins are glargine U300 and the degludec only. Onset is going to be extremely slow, which is not really important here, maybe around 1.5 hours to 4 hours, and it's going to provide a full 24-hour true coverage of stable basal levels of insulin, which is going to mimic the pancreatic secretion. At the same time, there are some unique advantages with regards to degludec compared to that of the glargine U100 itself. What is that advantage? That is, you can take in any time of the day. There is no fixity of timings like glargine. So which means the things that are comparable with glargine is the fact that you can take in any time of the day. But remember, in glargine U100, you have to take at a fixed time, even though you take it any time of the day. Like 8 AM means 8 AM. But here, there is no fixed timings. You can take today at 8 AM, tomorrow at 5 PM, day after tomorrow morning at 8 AM. Doesn't matter at all, because the duration is 42 hours. So no need to worry about that. So there is no fixed timings. And compared to that of U100, similarly, you need not take with respect to the meal. So which means it can be taken irrespective of meal status. So one added advantage with that of glargine U100 is the fact that there is no fixed timings with the use of degludec. You can take it any time of the day, and even erratically, it doesn't matter. Just you have to take one injection per day, that's all. And there is a considerably reduced risk of hypoglycemia compared to other forms of insulin, because truly there is no peak. So which means even in fasting states, there is relatively no risk of hypoglycemia in this degludec. And I'll not tell no risk of hypoglycemia, relatively very much reduced risk of hypoglycemia compared to other basal forms of insulin. These are the true advantages of degludec. So how really degludec works? As I told you before, these changes in the insulin that the company has made had made the insulin to arrange themselves in something called dihexamers in the pen itself that contains this Tresiba. These dihexamers are going to be getting injected in the subcutaneous area, which will then form something called multihexamers. These are nothing but aggregates of insulin which forms a stable depot of insulin in the subcutaneous plane, so which will be released over a very, very, very long period of time. So they have a very prolonged action of approximately 42 hours. Comparable to degludec is the glargine U300, which is a newer form. It's available in the brand name called Toujeo, and it's a pharmaceutical race. We know that Novo Nordisk produced degludec in 2010. In 2011, Sanofi came up with glargine U300, which is also claimed to be an ultra long-acting insulin, not ultra long-acting up to the level of degludec, but claimed to have approximately 34 hours of action. It's having the same properties as that of glargine, but just by increasing the concentration to 300 units per ml, where U100 had 100 units per ml, this glargine U300 had 300 units per ml, just by changing the concentration, action is little prolonged and it's going to become an ultra long acting insulin. So this is again a truly peakless insulin, glargine U300 form. So now let us see the summary, review what all we have seen till now. What we have seen till now? We have seen the rapid acting analogs, which produces a very, very high peak among all the insulins, and that is important to produce a significant effect on the post-meal hyperglycemia. To control that, it's really needed. And next we have this regular insulin, U100, which is a typical short-acting form, produces a lesser peak compared to that of the rapid-acting analogs. Then we have the mixed short-acting and intermediate-acting, that is U500, which I have discussed already. So its profile is going to be mostly like a NPH only. And then we have the intermediate-acting form, that is the NPH, which I am shading in green now. And we know the profile. It has a distinct peak and there is a risk of nocturnal and midday time hypoglycemia if you are not taking any food. And then we have the long-acting forms like glargine and detimer. Detimer has a definite peak, as you can see here, but even though it wanes by around 20 hours. So we know that already. And glargine, on the other hand, the U100 glargine, it's a long-acting, not ultra-long-acting. So it maintains a very stable levels for a longer period of time. You can see here, it's going to maintain a stable level for a longer period of time, but even though it wanes by around 20 to 24 hours. So there is still a risk of next day morning hyperglycemia if you're going to give in the morning 8 a.m. But still it's not very significant with that of glargine U100. It's a very good basal insulin to start with. The other ultra long-acting insulins, glargine U300 and degludec, are truly peakless insulins. At the same time, they are going to work for a very, very longer period of time. So U300 usually wanes off by around 34-36 hours, whereas degludec usually will wane off only after 42 hours, which is a truly ultra long-acting insulins. So this is what we have seen till now. So with this, we have completed this and we are moving on to the sites, absorption, storage of insulin. As far as the insulin sites are concerned, we have 4 different sites. One is the posterior arm and the buttocks. And in the anterior side, you're going to use the abdomen, especially the lower and lateral portions of the abdomen and the outer thighs, lateral portions of the thighs. So these are the areas that you're going to use for insulin injection. If you ask which site has the fastest rate of absorption, obviously I'll go for abdomen. Abdomen is going to have the fastest rate of absorption, which is going to have the highest amount of fat. Buttocks is going to have the highest amount of fat. Least amount of fat is the arm. Arm is going to have the least amount of fat, and abdomen and outer thighs are going to have intermediate amounts of fat. Which is the site that is associated with the most erratic absorption? Buttocks. So this is the site that's going to have the most erratic absorption. That is the reason why buttocks is one site that has to be avoided for insulin injection. And as far as the studies are concerned, there is no significant difference in choosing a particular site for injection. But most important point is the fact that you have to rotate the sites to avoid some complications like lipodystrophy. So you have to adequately rotate the sites, even though glargine is better given in the thighs, but there is no standard consensus like that. You can use any site, but better avoid the buttocks because of the erratic absorption. And you also have to note what are the factors that affect absorption. Factors that favor absorption or factors that defer absorption, we have to know that. The first factor that's going to affect absorption is going to be the IM versus subcutaneous route. Suppose if you are going to have an inadvertent IM injection, they are going to be associated with a faster absorption. At the same time, if you are exercising a particular limb, in that setting you will have a faster absorption because of faster washout because of more blood flow to that particular area. And site also matters. As I told you, abdomen is the site that is associated with the fastest absorption, which we have discussed already. And there are some things that are associated with slow absorption. For example, if you are giving very high dose, So same effect, when you're increasing the concentration of a particular insulin, even in the vial, they're going to have a prolonged action and a slow action. Similarly, you're going to use a higher dose of some insulin. The local concentration will be high so that they'll be having a prolonged and a slow action. So when you're giving a very high dose of a particular insulin, you can expect to have a slow action. And at the same time, if the patient is having a lipodystrophy in a particular area, we'll talk about that in detail sometime later. So lipodystrophy in a particular area, that is associated with the slow absorption. So these are the factors that are associated with faster as well as slower absorption. Apart from that, there are some side effects of insulin therapy. So what are the side effects? Side effects are not many. Insulin is considered as one of the most safest drugs to start with. So, but there are some side effects of insulin as well. Suppose if you are using an IV insulin, the most significant side effect that is with IV insulin is the fact that you might end up with a hypokalemia because of activation of sodium potassium ATPase. Remember, this is seen only with IV insulin. With subcutaneous insulin, even with very high doses, this effect is very, very uncommon. Only for IV insulin, you have this side effect of hypokalemia. Apart from that, you might have pain and irritation at the site of injection. Probably this is associated with intramuscular injection. You have to review the patient once again why they're having pain. So intramuscular injections are associated with pain usually. So how to avoid intramuscular injection? So you have to pinch the skin. Suppose the patient is not having sufficient fat, if the patient is very thin, which is very true in the setting of type 1 diabetes mellitus patient, and especially if you are injecting in arm, which is naturally tend to have a lesser fat, it's better to pinch the skin with 2 fingers like this and then inject the insulin. Apart from that, if the needle is reused again and again, multiple times, you might have a pain and a irritating sensation. Apart from that, glargine use itself can produce a site of a stinging sensation, which I discussed already. So avoid the stinging sensation to a great extent, bring the glargine down to the room temperature and then use glargine. That's the idea. And the oozing can happen. So once you have injected into the subcutaneous area, so when you take the needle out, there might be a small amount of insulin that can ooze out, maybe 1 or 2 drops. That's not going to cause a real problem in clinical practice. But if you really want to avoid that oozing, and if you're really scared that oozing will result in reduced dose of insulin delivered and hyperglycemia, then it's better to keep the needle in situ for 10 to 15 minutes after injecting and then having a slow withdrawal. So that will avoid this kind of a oozing related complication. And bruises can be formed sometimes, very rarely. So bruises are usually due to usage of larger needles. So you can use a small needle, which we'll be discussing subsequently, and avoid shaking of hands. This is very true, especially if it's a Parkinson patient or a patient with essential tremor using the insulin injection to self-inject insulin. They might shake the hands so that you might get a bruise. So avoid shaking of the hands, or if there is a severe shaking of the hands, the setting of essential tremor or Parkinson's or due to some other reason, ask someone else to inject the insulin for you. You need not inject the insulin. And finally, there is something called bubble formation, which is a real problem, because bubbles create a dead space within the pen or within the insulin syringe, so that if you don't remove that bubbles properly, then that bubbles also might enter along with insulin. It's not going to cause a side effect like a hair embolism, but still it's going to reduce the total dose of insulin delivered, because that bubble contributes to some amount of insulin units in the syringe and the pen. So that's why whenever the patient is taking a low dose of insulin, like 5 units or 4 units, these bubbles may contribute to 2-3 units. So the net dose delivered to the patient will be only 1 or 2 units. So higher dose doesn't matter, but for lower doses, when there is a significant size of the bubble within the syringe or a pen, it's better to discard that bubble. Especially in the setting of a pen, there is something called a priming. So you turn the pen upside down so that the air bubbles come up. So you first let the air bubbles out till you get that insulin out. So you have to see the insulin in the tip of the needle. So that it's better to waste that 1 to 2 units of insulin, that's fine, along with the air bubble. So that process, what we refer to as something called a priming. So priming is a very, very important process to avoid the inadvertent lower dose of insulin getting injected, especially in patients who are using low dose of insulin, especially in the setting of children or neonate, where they need only maybe 4 or 5 units of insulin per injection. And another realistic problem is the lipodystrophy. So lipodystrophy can be of 2 types. One is called lipoatrophy, and second is a lipohypertrophy. Lipoatrophy is due to local production of TNF-alpha, which produces atrophy of the adipocytes and local lipoatrophy. And this was very common when we have been using animal insulins, porcine and bovine insulins, where there will be an immunological reaction for these proteins because they are foreign anyways. They are coming from animals. So currently with the use of human recombinant DNA technology, this is very rare, but still in present conditions, this is seen in increasing frequency in patients who are using continuous subcutaneous insulin infusions. We are seeing the resurgence of lipoatrophy in patients who are using continuous subcutaneous insulin infusions through insulin pumps. And lipohypertrophy is also a rare entity, but it can still happen if the patient doesn't rotate the sites properly and they're injecting the insulin in the same area for a longer time, because insulin has a direct anabolic effect on the adipocytes. So they can produce more proliferation of the adipocytes and they can produce more fat in the local area, resulting in that lipohypertrophy. The problem is if you are going to inject insulin again in the area that is gone for lipodystrophy, you are going to have an erratic absorption of insulin. So in fact, you are going to have a slow absorption of insulin, so you have to be very careful in that setting. And similarly, injection of insulin can very rarely produce local reaction. So in this setting, it's better to change the insulin. It's very rare entity with the current insulins, but if they get a local reaction, it's better to change the insulin. But most of the time, the local reactions will be due to the preservative rather than the insulin itself. So it's better to change the insulin to a different type of insulin with a different type of preservative. The patient might not be allergic to that particular preservative in the different insulin. And you can use some local steroid creams if you really have a difficult allergy to treat with. And sometimes even desensitization help. If the patient is having allergy to most types of insulin, then desensitization may be helpful in that clinical setting. But apart from that, allergic reactions to current insulins is generally very, very rare. And it's usually will be due to the preservative rather than the insulin itself. That's the take-home point. And as far as the storage of insulin is concerned, the temperature that is recommended is 2 to 8 degrees C. That's the temperature that is recommended, which means you need a refrigerator to store an insulin. In fact, if the patient is not having a refrigerator, then you can use something called an earthen pot that provides a cool kind of an atmosphere, which is available in most of the low socioeconomic status people as well. And the second thing that you have to note is the fact that you should avoid freezing. Refrigeration means it's refrigeration, we're talking about freezing. Freezing will result in complete loss of efficacy of insulin. So do not freeze and try to avoid direct sunlight as much as possible. And the shelf life of insulin is something to be noted. So in room temperature, the shelf life is approximately 1 month, whereas if you are refrigerating the insulin, the shelf life is approximately 3 months. Remember, WHO recommends the insulin's efficacy should be at least more than 95% at the time of usage, or probably you can also tell like the loss of efficacy should be less than 5% at the time of usage of insulin. So this is the WHO's quality recommendation with respect to insulin use. We are moving on to the devices now, insulin devices. We have a lot of devices available right now, and the syringes are the mother of all insulin devices, which is available for the last 8 to 9 decades from the time of discovery of insulin. And we have the insulin pens, which are very famous right now. Then we have very modern devices like iPort, and we have devices like InsuJet as well, which does not use any needle at all in the first place. So what about the syringes? These are traditional way of giving insulin to a patient. To be honest, the only advantage that syringes have is it is having the least risk of malfunction compared to all the other devices, because you are seeing the syringe needle directly that goes into the skin under your supervision, and you are going to push the plunger on. So which means it's having the least risk of malfunction, but it is having a relatively higher risk of getting pain upon injection and a relatively lower accuracy compared to the pens, because it's manually taken. That's why manually taken means always having a risk of inaccuracy. Apart from that, you know the sequence of injection properly, especially if you are using a split mix regime, which is very important, because the name split mix came because you're taking the regular and the NPH separately. Pre-mix is fine where the regular NPH will be together. That's a separate form of insulin therapy. But in split mix formulations, it's available separately for different reasons, which we'll be discussing subsequently. But the sequence of injection in split mix regimen are very, very important. You have to always take the regular insulin first, then you have to take the isofan insulin. So you should not do the other way around. So first always regular, isofan always the next. Why? Because if you're doing other way around, for example, if you're taking the NPH first and you're putting the same needle into the regular vial, and there will be some 1 or 2 drops of NPH that can enter the regular vial. So NPH contains protamine, we know that. And this protamine can enter the regular insulin vial, and they can convert the regular insulin into a NPH insulin in the regular vial. So over time, with consistent reverse use like this, you will have 2 vials of NPH alone, you will not be having one vial of regular and one vial of NPH where you started with. So to avoid this sort of a confusion and complication, always better to take regular first and NPH next, which is a very, very important point to know. And you have to tell the proper technique. What is the technique that you're going to follow? You have to follow something called a 2-finger pinch technique, which I've described already. And it's better to inject at 90-degree angle, perpendicular to the skin surface. And you also have to follow safe needle disposal with regards to insulin syringe use, where the needles are going to produce a real threat of carrying some infections and getting transmitted to others in case of inadvertent needle stick injuries. And apart from that, you should also know the fact that glargine should never be mixed with any other insulin because of their acidic pH. Remember, NPH, Detamir, Degludec can be mixed with regular insulin or probably with some other rapid acting analog, but glargine should never ever be mixed with any other insulin because of its acidic pH. And with regard to the pen, pens are associated with lower pain and relatively higher accuracy, and the needle phobia will be much lesser with that of the pens, because in insulin syringes you are seeing the needle directly in your eyes and you are injecting, so the phobia is a little high, whereas as far as pens are concerned, you don't see the that needle that coming out by your eyes. So the needle phobia will be a little less compared to that of the syringes. Yes, that's one more advantage. And at the same time, pens cannot be used for split mix regimens. It's not for split mix regimens, but even though it can be used for pre-mix combinations. And at the same time, the needle size is also very, very important. The standard needle size as far as the pens are concerned is approximately 4 to 8 millimeter, to be honest. So where 4 millimeter needle size is associated with lesser pain, more accuracy, and at the same time, it's having low risk of intramuscular injection. And for all the sites, you can use 4 millimeter without any problem at all, because there is no point in having intramuscular injection with 4 millimeter size needle. So 4 millimeter is the one that is preferred. But if you're going to use 8 millimeter size needles, there is a little increased risk of having intramuscular injections. At the same time, there will be increased risk of having pain as well. So usually with pens, there is no need to lift the skin or pinch the skin. Suppose if the patient is having very less fat, so then there is a role for lifting of the skin, especially if you are injecting in the arms. Suppose if you are injecting the abdomen, even with lesser fat, there is no point in lifting the skin or pinching the skin, because usually 4 millimeter needles that we are currently using are not going to have any much risk of intramuscular injection. And one more important point about the pens is the fact that bubble formation is the realistic problem. Compared to that of the syringes, the bubbles can be formed, which is very difficult to take out as well in the pens. So that's why, especially for the pens, priming is really, really important, where you have to turn the pen upside down and you have to let out the bubbles along with 1 to 2 units of insulin. And that process is what we refer to as something called priming, which is a very, very important process. And coming to the next sophisticated device is the iPort. You can use it for people who are having severe needle phobia, especially with regard to that pain part. So what iPort really does is it has a depot-like structure which is above the skin surface. So there will be a cannula that is projecting under the subcutaneous area. So what you really have to do is you need not really inject into the skin every time. So just you have to inject this into this depot. That will push the insulin into the subcutaneous area. So it's a very good device that to avoid the pain because the needles. It's a very interesting device. iPort is not very popular, but you can use in patients who are very afraid of the pain because of the needles. And then we have Insujet. It's a very costly device, and it's a very interesting device again. What Insujet really does is it's going to produce a high velocity jet and a very thin stream of jet, thin enough to penetrate the cutaneous pores. The pores between the skin, it will penetrate through that pores and they will go into the subcutaneous area directly without any needle at all. So this is a true no needle technique. So Insujet can be preferred in children especially who are having severe needle phobia and they are adamant not to use any needles. In that setting, you can probably prefer Insujet. It's a very interesting device, but still it's very costly and you have to carefully select which patients will be benefited from Insujet. We use commonly in children with extremely severe needle phobia because needles, they are not taking insulin properly, then Insujet may be an option for them. So next, we are moving on to the most important area, that is the dosing and the regimens. So to start with, we are going to discuss on the dosing first of the insulin. So if you really want to know the dosing, you need to know the insulin requirement, which is a big headache most of the times. So what is the insulin requirement for a particular person? So it's really difficult to determine, as I told you multiple times, but the standard and the usual starting dose of insulin is this. For example, for augmentation purpose, because in diabetes mellitus patients who are suffering from type 2 diabetes, you can use initially augmented dose. So just to boost up the oral therapy. That's called the basal subud oral therapy, which we'll be discussing subsequently. For augmented doses in type 2 diabetes mellitus, you can start at a dose of 0.15 units per kilogram per day. But if you're using as a replacement therapy, this is very true, especially in the setting of type 1 diabetes mellitus patients. You can use a dose of 0.55 units per kilogram per day. So this is the standard recommended starting dose, but even though there are considerable variations. So it's not that simple. So you need to know about the factors that affect the insulin requirement and insulin dosing. So what are the factors that alter the insulin requirement? So first is the age, of course. Second is the pubertal status, which play a very, very important role. Then we have the duration of diabetes. The longer the duration of diabetes, more will be the insulin requirement compared to the beginning of the diabetes mellitus. And then the injection site is important, because if you're going to use at the buttocks, then there can be erratic absorption. The site also matters a lot. Then the nutritional status. How much carbohydrates they are consuming, the clinical state of the patient, whether there is a post-decay state where the insulin requirement may be very high, which we'll be discussing subsequently. And at the same time, what is the level of physical activity? Low physical activity means higher insulin dose. Higher physical activity means lower insulin requirement. So physical activity also plays a very, very important role. So let us see two examples. As far as the pubertal life is concerned, this is a very, very important point, because the insulin requirement pre-puberty is approximately 0.6 to 0.8 units per kilogram per day, which is the same as the usual replacement starting dose, that is 0.55 units per kilogram per day. We are talking about type 1 diabetes mellitus, disclaimer. And at the time of puberty, the dose will be very, very high, to 1 to 1.5 units per kilogram per day. This is because of the counter-regulatory hormones that are growing in excess, because the cortisol, ACTH, glucagon, growth hormone, everything will be in excess at the time of puberty because of the growth spurt that's going to happen at the time of puberty. So the dose that is needed to counteract this counter-regulatory hormones is going to be higher. So that's why insulin is required in higher doses at this point. Then post-puberty, it will come to a standard of approximately 0.8 to 1 units per kilogram per day.